Each year at the University of Alabama at Birmingham School of Medicine, my colleague Dr. Tom Huddle stages a miniature debate for the entering medical students regarding the Affordable Care Act. Over about 30 minutes, we touch on a favorable view of our future under the Affordable Care Act and a pessimist's view of the impact of that law, which leads into a panel discussion. This year's debate was recorded, and the first few slides at the beginning were cut off, so I'll be recording those slides privately and merging that file into the live debate, which will create the full video. My name is Stefan Kertész. This is the positive view of the Affordable Care Act. It's important to share with you my premises when we talk about why I come to a favorable view of that law. First, we should try to help people. I think almost everybody agrees with that. The second is we should know that the consequences of not helping people. That is, what is the alternative?
And the alternative scenario. We should understand that many good things cost money or have downsides. If all good things had no downsides, life would be mighty easy, wouldn't it? If those costs or downsides are modest or the benefit is large, we should go with helping people. This one might be a little more complicated, and certainly more words. We should not apply a uniquely stringent standard for helping people who are poor if we're not applying that very same standard when speaking about helping people who are middle class or wealthy. It's going to have to at least be an equal standard, if not a preferential standard for the poor. We should be realistic about our political environment when advocating for change. And those principles lie behind the argument I'll frame. But let's start up with, what were we dealing with? Why was this law passed in 2010? What was the urgency and the concern? So just as one parenthesis on the talk I gave the other day, being uninsured is bad. You can see a comparison of countries here, looking at people who didn't see a doctor or get care because of being uninsured. That's the beige column that reaches to 58% on the right. And you'll see that these folks were also more likely, if they were uninsured in the United States, to not fill the prescription and more likely to have had more than $1,000 out-of-pocket expenses. The U.S. insured don't do that great either because the out-of-pocket costs for insured people have risen. But still, uninsurance really adds a new measure of problem. Some other things to point out about uninsured status and why it's such a serious problem. There's worse access to care. This is causal and proven through randomized controlled trials. People who are uninsured and hospitalized face something like 4 years of financial setbacks with a 170% increase in unpaid medical bills and double the likelihood of bankruptcy. Think of all the family chaos that causes. People who are insured are less likely to defer medications or doctor's visits, better self-reported health, which is a measure that actually predicts mortality, although we don't think of it as objective. And they have an improvement in the use and receipt of care, and that's proven in randomized controlled trials. Insured people have lower mortality, and that's from quasi-experimental data. So there's room to debate. It looks at state comparisons between states that expanded Medicaid and those that didn't. So maybe we can debate whether that is true. But do think about the harms, not just to patients, but to children and families, and to families as a whole, when health care is delayed or foregone or proves financially catastrophic. This is serious business. The pre-ACA insurance market, vehemently, I say good riddance. The market worked on underwriting and the rejection of potential consumers. In government accounting office surveys, the denial of policies among persons, frank out denial among people seeking to purchase insurance, was 19 to 22%. Those are two different GAO surveys. So a key part of the market and why it worked well for people in it was making sure a fifth of potential purchasers couldn't get in it. In 2008, a different survey by Commonwealth Fund, among insurance shoppers, I don't know quite how they got the sample, but it was large, 57% said it was difficult or impossible to find an affordable plan. 70% said that if they had a prior health problem. Pregnancy wasn't typically covered unless you purchased special riders, which weren't always available. There was rescission of policies based on past paperwork errors, essentially bad faith actions by insurers. The prevalence of that was actually low. But having 10,000 or 20,000 people who've had that experience, even in a country of hundreds of millions, can create a lot of discomfort and uncertainty for many other people. But it wasn't the case that insurers routinely did this, but it was a serious issue. What does the ACA do? So before I defend it, just to remind you, there's this Medicaid expansion, optional for the states. Everyone gets access to an insurance market. Insurers can't deny based on pre-existing conditions. They can't really price based on health. They're allowed to price differentially based on, I think, age, sex, and tobacco. Is that right? I think tobacco status is still included. Can't refuse to cover pregnancy or mental illness. There was a law passed before the ACA on the mental illness front, but it's still not fully enforced. No lifetime maximum of benefits. You know the young adult retention on parental plans until age 26. A mandate on employers to provide based on the size of the employer down to 50. Somebody corrected Dr. Curry. A personal mandate to purchase enforced essentially through what you fill out on your 1040. If you're filling out your tax form and you didn't meet the mandate and you don't meet one of many exception clauses, you have to pay a fee. And it turns out we have one of the most honest tax systems in the world. That is, Americans are more likely to pay their taxes forthrightly than the average country out there. And expanded efforts to save on Medicare, where we can debate at length which parts of those savings were real and which kinds were just kind of illusory. Coverage gains, my estimate, Tom may give you a slightly different one. It is the case that 20 million more Americans are insured in 2015 than in 2010 using the National Health Insurance Survey. You may not want to say that every bit of that is caused by the ACA. It's okay. Medicaid did grow by 14.9 million since 2013, which was, in 14 the expansion occurred. 8.9 million of those people were, in fact, newly eligible for Medicaid based on the change in criteria in those states that expanded Medicaid. 5 million kind of just, they were already eligible, and they sort of crept out of the woodwork to apply. The total individual insurance market grew, per the Kaiser Family Foundation, from 11 million to 19 million, and about 58% of the individual insurance policies were purchased on ACA exchanges. About 80 to 90% of people purchasing on exchanges receive assistance in that purchase. And employer-provided insurance didn't shrink. There's a lot of survey data on this. That's not to say that no employers, we're going to come back to what employers have done in some ways to reduce their exposure, particularly small employers. But on whole, the stats didn't change. And I showed you the graphs on that 2 days ago. What's the impact of Medicaid expansion on individuals? It's quite large. Here's a study from just, I guess, a week ago that Dr. Durant was kind enough to provide me with. 8,676 adults in 3 states, 2 which expanded, 1 which did not. And they're looking at differences over time and what gains occurred for people in the expansion states, actually 2 different kinds of expansion between Kentucky and Arkansas, and a non-expansion state, which was Texas. It's a quasi-experimental study. We can argue that there are causal relations here. We can't prove them. But, broadly speaking, the percentage of people who had a personal physician, who had regular care for a chronic condition or a checkup in the past year, grew in those expansion states relative to the non-expansion state over the time being studied. In terms of other things, having ED visits, trouble paying medical bills, cost-related delays of care, being uninsured, those things shrank. That's statewide. So that's a pretty big change. Another study looking at financial impacts of getting Medicaid on a person or a family. Comparison between Medicaid expansion and a synthesized mean of non-expansion states. There's a lot of complicated economist reasons why they chose that approach, but essentially amounts to looking at differences achieved over time between the expansion states and those that didn't do that. Medicaid expansion was looked at by zip code area, so they're not looking at every person who received Medicaid, but by every poor zip code in the areas where expansion was available. Medicaid expansion reduced the amount of debt and third-party collections among persons living in the top quartile zip codes for poverty and uninsured status. So if you're in a poor area, basically, fewer people were in debt or having debt sent to collections if you were in a Medicaid state. The effect on the people actually receiving the Medicaid was estimated at $600 to $1,000 less than the amount sent to collections. This means less unpaid bills, greater access to credit. What are the experiences with new plans? Here you begin to see some flags of concern. Greater than 50% of people purchasing on the exchanges say they were uninsured before they bought it. That was from 2014. I think Tom will suggest, and there's plenty of room to argue, but that on the exchange purchases may have a significant number of uninsured people, but a lot of people are buying insurance off exchanges, and a lot of those people were previously insured. The 66% of people rated their coverage as excellent or good. That's a tick down from 2 years before, so there's a hint that there's some concern about the coverage the plans are providing. Only 45% rate their plans as the plan itself overall is an excellent or a good value for dollar paid. That's a concern, and that's lower than in 2014. So we have some hints of trouble, despite my role here in playing the optimist. Now, every year is sort of projected disasters. We've done this debate for 5-6 years in a row, and half the disasters projected by Tom, sometimes before me, sometimes after, simply have not come to pass, and others have kind of at least lingered as concerns. I've thrown up a bunch of them here. We're going to talk about several of them seriously. The notion that employers would jettison 35 million Americans from employer-provided insurance was spoken here to your predecessors. I argued vociferously against it, and it simply did not come to pass. So just be aware that not every disaster spoken about by my esteemed colleague always comes to pass. But I put in yellow and in white ones that might be a concern. What about employers and part-time work? Will people choose to work less? Will the cost burst the federal budget? Maybe the ACA won't resolve all the problems in our health system. I put them in different colors because they have slightly different attitudes, but they all deserve consideration to a degree. I want to focus for a moment on some of these criticisms because they have some reality to them, and they need to be considered when you ask yourself about the value proposition of passing this law versus not having passed it. One is called the lost labor criticism. Think of this. When the government offers a benefit, offers any kind of benefit, it can affect the sales of labor or service or property. Think about the mortgage income tax deduction. I can deduct from my income tax a portion of the interest I pay on my mortgage. That causes me to purchase bigger houses. That's been proven. It also causes people who own rental property to convert it to property for sale for ownership because they can fetch a higher price in the market. So this is undoubtedly true. And if a social benefit, now we're talking about Medicaid, think about that, or any other income support, if it's reduced as income rises, we call that means testing. It's a way of targeting to the most vulnerable. And that may indeed reduce people's desire to seek work or income, because when you seek new work and you lose a benefit, the gain isn't as big as a gain when you're not losing a benefit. It's kind of it's an implied tax. On the other hand, better health or less disruptive health emergencies might improve employment, or they might improve people's hours worked. They might reduce their use of other social programs. So we can't be positive that always happens in every situation. But according to the CBO, Congressional Budget Office, the means-tested design of benefits under the ACA, and by that I mean the Medicaid, which you only get if you're below a certain income, and also that loss of premium supports as your income goes up, is thought to potentially reduce the labor supply by 0.8%. And there have been even higher estimates. People may choose to work less if they know they're not gaining the full value of their increase of work. So I don't want to completely deny that. Does Medicaid itself cause people to stop working? The Oregon Health Insurance Experiment randomly assigned people to be eligible to apply for Medicaid. Among 61,000 people they analyzed, they found no significant effect on earnings or employment. So at least on the Medicaid side, we have a randomized controlled trial saying it doesn't have that effect. But that doesn't take away from the fact that those tiered benefits where you get premium support on the exchanges might still have that effect. Now let's just think about loss of labor supply as one more quasi-concern / disaster. And I want to read you a historic quote from a study in the 1970s, another loss of labor that was decried by its critics enormously. Not unnaturally, free black families wished to enjoy some of the free time they were denied as slaves. Freedmen demanded the right to work fewer hours, to have at least one day off, and if they were married, to have more free time with their wives and children. The result was a dramatic fall in the amount of labor that free blacks were willing to offer as free laborers. This decline in labor effort produced what contemporaries claimed was a shortage of farm labor, a phenomenon that whites attributed to an unreasonable refusal on the part of blacks to work for wages. In fact, what had occurred was a perfectly reasonable response to freedom on the part of blacks. I am not saying, just to be clear, that if you hold up the labor loss argument that you advocate for slavery. Far from it. I'm just saying that every decision sits in a moral and a values context, which only you can decide for yourself what the moral value is or the value context that you want to apply for it. So in this particular case, we'd all laugh this labor argument right out of the room. You have to decide how much value you want to place on any given cost or downside to a law. Value judgments lie at the core of our debates. When you hear a number profiling a disaster, listen and think. Make sure you're not trapped into theoretical paths whose logic you would disavow if you saw it exposed. How about involuntary part-time work? Involuntary part-time works may shield employers from benefit jobs. You convert your full-timers to part-timers, and you avoid potentially an ACA mandate. ACA mandates may be contributing to such involuntary part-time work. You see part-time work, involuntary part-time work is the blue curve. It's going down just as unemployment is going down, but not at the same pace. And that difference might reflect some action by employers, particularly, and research suggests it's retail, food, and hotel industries. Not every study agrees with that. So there may be some of that really going on. What about premiums? I took one from every year from Breitbart.com. So the first thing we have to deal with is premiums made a major drop right when the AC exchanges opened relative to what they were in the individual market before. This is from the Brookings Institution. It may be that the competition or the influx of new customers and market seeking and underpricing by insurers led to this drop. But that's important to know. There was this drop, and I think we're seeing a kind of bounce back. Annual premium changes, different estimates. Charles Gaba is the one that's most aggressive, but he actually seems to be the most thorough. But for 2017, summary of requested rate increases across all states, 24%. I don't know why Kaiser has a very different approach. They say 9%. Everyone agrees the premiums will go up more this year compared to prior years. Time? 5 minutes? 1 minute. Oh, I got to show you some other stuff. We'll skip on cost then. OK, let's just talk about cost for a second. So you've heard from Dr. Curry, we have major cost problems in healthcare in the country. I want to put this in context. We do. The 2024 projected cost for our total national health expenditure is $5.3 trillion. If you include federal health expenses with the tax subsidies for employer-provided health insurance, it's $2.9 trillion. Just the expenses, $2.49 trillion. The projected 2024 cost of the ACA coverage expansions is $0.16 trillion, i.e. $160 billion. To focus on that may not address the $5.3 trillion. In fact, hardly will at all. Which budget hits matter most? ACA net costs being $156 billion projected in 2024. At this point, they're actually covered by Medicare savings, but I usually don't weigh that too much. Or all these other things which I include myself, middle-class employed people get. A mortgage interest tax deduction, an employer insurance tax subsidy, an extension of the Bush tax cuts, which were priced at $519 billion for the same year. My final argument. Lacking coverage is devastating. The ACA simply did not reform the vested interest amalgam that is our health system. Arguing it should have done so is a kind of idealism. The $5 trillion problem of national health expenditures exists, and it will exist with or without the Affordable Care Act. ACA covered 18 to 22 million people at a cost of 5.5% of total health expenses. Arguing that ACA's coverage for the uninsured should have been delayed until we reached a magical consensus on things we haven't agreed on since 1965 borders on cruelty. For insured middle-class people to protest ACA's care expansions as costly and distortive of the market, while themselves keeping more costly and more distortive employer-sponsored health insurance, Bush tax cuts, and mortgage interest tax deductions, which we do not debate anywhere, reflects a moral blind spot. Most religious traditions express a preferential option for the poor and needy, not for the well-off and secure. No law is perfect. Everything has its cost. This one does a lot of good relative to the cost. Thank you very much.
It's encouraging, Stefan, that the more we do this, the more we find to agree about. And I especially agree with the first part of what you said about, we want to help people, which we should want to do. I guess it's a little more difficult to respond to the attempt to tar those who worry about labor force participation with slavery, which, what a piece of rhetorical moderation that was. And the accusation of cruelty, I like that too. I mean, that's very encouraging. Now, I guess the first point I want to make, you have learned, at least in one of the sessions we had, that much of what we know on the basis of authority. And I just want to caution you that perhaps the authority figure you've just heard from, perhaps you should take what he says. Take what he says with a grain of salt. But leaving that aside, not that I would want to, associate Dr. Cortez with anything unsavory. So go ahead and answer the question that Dr. Curry asked, which I ask in a slightly more nuanced fashion. Okay, interesting. Actually, probably less approval of the ACA than in years we've had in the past, during which things have been a little more evenly split. And it's certainly true that if you look at the polling, I mean, the ACA has never gotten 50% approval or more. I mean, literally since the day it was passed. And approval of it has actually shrunk in recent years. And that's really not surprising when we actually start to look at what the ACA has actually done. And I'm going to say up front that I agree with Dr. Cortez, and I agree with what Dr. Becker said yesterday, that not having insurance coverage is a horrible thing, and that we need to have people obtain insurance coverage. And my main quarrel is going to be not with the fact that that has happened to a much larger extent than previously. I mean, I think that's great. But I think the test of good public policy is not that we look at one of its good results and therefore conclude that, aha, this is great. I think we have to, public policy always has lots of different things that it does. And we have to look at the aggregate of its effects and compare that aggregate with alternative possibilities. And my argument's going to be that it's not going to be setting a particularly high bar to suggest that the ACA falls short. Now, in regard to coverage, I think Stefan showed you this the other day, and the drop in coverage, probably much of it attributable to the ACA, has certainly been dramatic. It hasn't really solved the problem. I mean, if you look at the data in this way, as opposed to the way that Stefan showed you the graph, which was notably successful at hiding the fact that there are a lot of people that are still uninsured. The ACA has had some effect. It hasn't really dealt with the problem. I mean, there are various estimates. I mean, Stefan said 20 million. I'm not going to disagree too much. Probably 17 to 20 million, somewhere in that ballpark, is very realistic. I mean, there have been various studies of all of this, and the caveat is that lots of things have happened. People go in and out of insurance for lots of different reasons. Attributing particular numbers specifically to the ACA can be a difficult thing. It seems clear that its main effect has been the Medicaid expansion. That's where most of the increased coverage has occurred. The exchange, I mean, there are a lot of people in the exchanges. Most of them were probably previously insured in one way or another, so that number's a little bit less related to the number of actual people that got new coverage. Now, Stefan, mentioned the fact that the cost curve appears to be bent. The cost curve has temporarily been bent. I mean, the rate of increase in recent years has been less than it was before. However, if you notice, that diminishing of the rate of increase started roughly 2008. It's very unlikely that the ACA has had anything to do with that. Probably most of it is the effect of the recession and other market conditions. Those economists who have looked at that with economic models have mostly come up with that conclusion. The ACA probably has relatively little to do with any diminishing in the rate of increase in healthcare spending. And healthcare spending has started in the last year or so to jack up again in regard to the rate of increase. Now, the fate of employer-sponsored health insurance, I think, is an important issue. And Stefan, made the point that, in spite of predictions of disaster, disasters really haven't happened yet. Now, he said that there's been no shrinkage in employer-sponsored health insurance. Actually, there's data that suggests that there has been some shrinkage. So far, it hasn't been very much. There's probably somewhat less employer-sponsored health insurance than there was a couple years ago. But right now, the effect is not great. However, the full package of ACA provisions really came into effect only in 2014. This is still early days. The fact that disaster hasn't happened yet does not mean that disaster may not be in store. And in fact, the Congressional Budget Office does predict that there's going to be substantial shrinkage in employer-sponsored health insurance in the next several years, which would not be at all surprising because, after all, the mechanism is there. The incentives are there. There are lots of reasons why employers, particularly of lower-wage employees, would want to get them into the exchanges and not have the responsibility of providing them with health insurance. Now, the exchanges, as you know, were designed actuarially to have a lot of young and healthy people in them so that the risk pooling would be successful and it would not consist primarily of older people who were sicker. That's what's necessary for the premiums to be affordable and for the insurance market to work, as we discussed. Now, the early results in regard to the composition of the population that got insurance through the exchanges wasn't as good from an actuarial standpoint as it should have been. Now, the big question has been, will that improve? Is it improving? And the answer so far is basically no. At this point in 2015, 35% of those who were eligible for the exchanges actually signed up. That's probably not going to change very much for 2016. And the numbers of young and healthy are low, and that distribution hasn't really changed 2016 compared to 2015. We're hovering in the range of 28% of young people as opposed to 40%. And for older people, we have more than predicted, and that makes this difficult from the standpoint of premiums being affordable to attract people to actually buy them. So is this playing out as one might predict from an actuarial standpoint? I mean, are the premiums going up in a really spectacular fashion such that we need to worry about a death spiral? Now, Stefan, I can't remember if you mentioned this or not. I mean, premiums did not go up a huge amount in this past year. I think the average rate of increase, 8.5%. Correct. But it was only 8.5% during the last go-round, which seemed encouraging to those who want to take an optimistic view. Perhaps this will all work out. What that 8.5% number doesn't reveal is the fact that the mix of the character of the insurance policies changed drastically between 2014 and 2015. Out-of-pocket costs were a much higher proportion in 2016 compared to 2015. Deductibles were much higher. So the cost to the buyer of the insurance was not simply the premium being paid, but also how much they had to fork out for health care before the insurance actually began to kick in. And if you look at a number that actually accounts for not only that, but also for the amount of money that insurance companies claimed through a risk corridor reinsurance arrangement, the thought was if they lost too much money, well, maybe the government would give them some, or they would collect some from other insurance companies that made money to make good their loss. The actual difference between the cost of enrollees before the ACA compared to the very recent past with the ACA is probably roughly 70% increased since 2010, and probably 58% of that is directly attributable to the ACA, compared to there would have been 11 or 12% increase without the ACA. Yeah.
Premium increases, are they predictive or are they responsive? So is it a response to the number of unhealthy people that got insurance coverage, or is it predictive of them saying, we believe this many people who are riskier are going to be joining, so we're going to go ahead and increase the premium?
Well, initially, of course, it was predictive, because nobody knew exactly what was going to happen. But what happened in 2014 was that the insurance companies lost their shirt. And what happened in 2015 was that the insurance companies lost their shirt. So each time they have to do this on a predictive basis, but their experience in each of the two successive years was a very negative one. So big increases in the cost of enrollees in the last couple of years. And that leads us to what's going to happen for 2017. Now, you know, you burn me once, maybe you burn me twice, do you burn me a third time? The rate increases that have been requested for 2017 are much higher than the rate increases for 2016. The national average at this point is something like 23%. Now, just looking at a couple of individual places that are close by, Tennessee, this is not a very encouraging picture. Without my glasses, I'm having trouble reading it. But on the right, 29% increase, 23% increase, 62% increase. These are requests for increases, and you know, United's pulling out of the market. And that's the other phenomenon we're seeing. Insurance companies are increasingly pulling out of entire states in regard to the ACA business in that state because they can't make money. Now, Alabama is a very interesting case. I mean, Blue Cross Blue Shield is dominant in Alabama. This year, we had 3 companies writing policies in Alabama, Humana, United, and Blue Cross. For 2017, Humana and United are gone. They pulled out. So we have a single insurance carrier writing policies in Alabama. What is their rate increase for 2017? It is 39%. 39%. So you may say to me, well, yes, there are these premium increases, but after all, you know, if the subsidies sort of take care of people at the lower end of the income scale, people aren't actually having to pay these premiums. So, you know, is that really a problem? And I would suggest that it is a problem. I mean, this is just an example, but a family now for a bronze plan paying close to $1,000 a month with a $13,000 deductible, I mean, that's sort of where some of these bronze plans are. So now with an 18% increase, which is what's been requested in North Carolina, that could go up to $1,150 a month. Might that make that family less likely to want to buy that policy, particularly if everybody is healthy and they have to pay $13,000 before they even could begin to collect on the policy? Now, of course, the whole premise behind this was that people would buy. People would buy insurance because they would be compelled to. And somebody asked the other day, you know, what exactly is the penalty involved with the mandate? And it's actually really kind of complicated. But the bottom line is, it's probably going to be $2,000 or $3,000 at the most. So you compare that with that $1,000 a month insurance premium. The arithmetic clearly makes not buying a policy, not a bad choice if you're not sick. So, completely unsurprisingly, who's buying the policies? The people that are buying the policies are the people at the lower end of the income scale who are very heavily subsidized. Those are the people for whom the ACA individual market component is actually working. For everybody else, it's not working very well. It's particularly not working well for young and healthy people who are maybe lower middle to middle class and higher, and who make enough of an income so that they're not very subsidy eligible. People like you guys, economically this doesn't look like a very good deal. And so it's not surprising that you guys are not buying this policy on a national level. So what's going to happen? This is sort of my little look, if you will. The exchanges are very likely to turn into Medicaid-like coverage with premiums and cater to a near Medicaid market with premiums mostly highly subsidized. Middle-class people may leave the individual market, and we may actually see a reversal of the trend toward more people insured. I mean, we may start seeing a trend toward more people uninsured just based upon the way the individual market is evolving here. Now, an interesting question. We talked about the fact that the public option didn't make it. But what made it instead? What made it instead were a whole series of consumer-operated and oriented plans. This was the SOP to the left, who didn't get the public option, but they got government support for co-ops. Organizations that would basically become insurance offering organizations, but they would be nonprofit, they would be non-business oriented, they would avoid all of the sort of profit motivation and commerce taint of the traditional insurance companies, and bring at reasonable prices good policies to people, because people was what they cared about. So what happened with that? The co-ops are losing their shirt. 15 out of 23 of them are gone. 1.7 billion in government startup funds vaporized. They are basically falling apart. I think all except for 2 or 3 of them are losing money. The rest of them are likely to go out of business. And I think the point to make is that these are the canaries in the coal mine. The co-ops do pure ACA exchange business, and that's all they do. They don't, unlike Blue Cross, they don't have the employer-sponsored market to fall back upon. They don't have other markets that are non-ACA to fall back upon. This is simply a harbinger of what's going to happen with the ACA exchange insurance business. Now, my final point is simply, what about the fiscal impact? The original projection, revenue neutral or actually revenue beneficial as far as the deficit is concerned, and we talked about the various ways in which that was going to happen. Now, at this point, the ACA is not so far proving as expensive as it could have for various reasons. We talked about the cost curve going downward a little bit. Not as many people have signed up, so there are fewer subsidies maybe than were originally anticipated. But the projections of cost, I mean, these various lines are still all roughly in the same area. So we're looking at substantially increased expenditures no matter how you want to shape it. But the prospect for the revenue-raising measures are a little more murky. The prospects for the Medicare cuts actually sticking is actually rather small. And the Medicare trustees are actually projecting a scenario in which current Medicare reimbursement rates persist and the cuts in the rate of Medicare growth don't actually happen. And politically, that's very likely. The taxes are being delayed. In December 2015, several of the taxes that were going to fund the ACA were delayed for either 1 year or 2 years. And this revenue that was going to, provide the money to pay for the subsidies simply isn't materializing. So, as Charles Blehaus showed in 2012, the actual likely fiscal impact of the ACA is likely to be greatly negative. The effect on our trajectory toward fiscal disaster is going to be to accelerate it even more rapidly than it is already being accelerated. Stefan made the point that, what's $150 billion if we can help people? And I don't completely disagree with that. I think it's a powerful point. But if the $150 billion is really IOUs, and the IOUs are sending us on a trajectory which is going to prove disastrous, particularly for you and your generation, not for me and my generation. For you and your generation that don't have much money, compared to me and my generation who have more money than you do, that's a problem for me. And the problem of declining labor force participation, which, as you see here, is not purely an ACA problem, but the ACA is going to add to it, that's a problem for me too, because it makes the economy less likely to be able to bear the fiscal disaster that we're facing. One argument would be, well, we can grow ourselves out of this through economic growth. Well, then the ACA shouldn't have made arrangements to actually dampen the economy rather than make it better. There are lots of incentives for declining labor force participation. There are some on the employer side. There are some on the employee side, because if you make $1 more and you go from being Medicaid eligible to being exchange eligible, suddenly your medical expenses go up by thousands of dollars. So you're not going to want to make that extra dollar. And the CBO, although this hasn't happened to a great extent yet, another of the disasters that that Cassandra, Dr. Huddle, keeps predicting, but that hasn't materialized, it is projected to materialize. So what do we got? I mean, we have some positives. We have people who have coverage now that didn't have it before. We put 9 million people into an insurance program that mostly provides substandard care, if providers are actually willing to participate in it, many of whom are not, which is, with its highly disproportionate to population growth rate of budget growth, crippling state budgets, preventing them from doing what they need to do in regard to education, law enforcement, infrastructure maintenance, you name it. Medicaid is an increasingly difficult burden for state budgets to bear. It badly needs to be reformed. We did not reform it. Stefan, the one point where Stefan and I agree, this was not healthcare reform. This was insurance expansion. And insurance expansion has its points, but in my view, it's a low bar to set, that when we did that, we should have done it in a way that didn't cause all this additional, unnecessary, completely avoidable damage, which might not have happened if we had done things differently. Now, I'm sort of a move in the market direction person, but I could totally understand. If you're a single-payer person, if we'd done that, then that might have been a much more economically logical way to go. Surely we could have done it better than this. Thank you. Okay, 10-minute break, and we will assemble. Or no. Yes, 10-minute break. Sorry.
me say thank you, Tom. You're making this so easy for me to attack. I was thinking, thank you so much. You're making this so easy.
I've got a bundle of other things I could get to. So we'll see if we come out of the discussion and keep my multinational. But you should, I mean, particularly I've got 20.
Well, I mean, I've got 40.
That's
I didn't talk about anything.
That's